Hello and welcome to this fourth year dermatology lecture. My name is Eliza and I am one of the foundation doctors at Sandwell Hospital. Today we will focus on psoriasis. By the end of this lecture, you should be able to understand the etiology of psoriasis, list the different types of psoriasis, describe the typical clinical features of psoriasis, explain the management of psoriasis and list some common complications. So what is psoriasis? Psoriasis is a systemic immune-mediated inflammatory skin disease. It typically has a chronic relapsing remitting course and tends to persist for life. It affects 1 to 2% of the population and affects men and women equally. It can occur at any age, but most cases present before the age of 35 years. And it is more common in Caucasians. The clinical features of psoriasis are explained by 4 key cellular changes. If you remember from your first year anatomy, keratinocytes are the cells in the epidermis that produce keratin. In psoriasis, these keratinocytes proliferate rapidly to cause a very thick epidermis, and keratinocyte differentiation is incomplete. Blood vessels in the dermis proliferate and dilate to cause redness of the skin, and inflammatory cells infiltrate. This is all caused by T cells, which produce inflammatory cytokines and stimulate the above processes. There are several different types of psoriasis to be aware of. Chronic plaque psoriasis is the most common form and the one that we will focus on today. It makes up around 90% of cases of psoriasis and causes well-defined red plaques on the body, scalp and face. The second most common form is localized pustular psoriasis, which causes yellow pustules on the palms and soles of the feet. The third most common form is flexural psoriasis, affecting 3 to 7% of people with psoriasis. Flexural psoriasis causes smooth, shiny lesions in moist body folds, rather than the scaly lesions seen in chronic plaque psoriasis. Rarer forms are seen on the right-hand side of the slide. Guttate psoriasis typically presents as small scattered papules called raindrop lesions on the trunk and limbs. It often classically follows a streptococcal throat infection and resolves after 3 to 4 months. 2 rare but important forms of psoriasis are erythrodermic and generalized pustular psoriasis. Both tend to affect people with pre-existing psoriasis. Erythrodermic psoriasis causes the skin to peel off in sheets, and generalized pustular psoriasis causes widespread pustules on red, tender skin. Both are medical emergencies and patients tend to be systemically unwell. The most common form of psoriasis is chronic plaque psoriasis, and this is the form that we will focus on in this lecture. Chronic plaque psoriasis typically presents as monomorphic, well-defined, oval-shaped erythematous plaques covered by a silvery scale. It usually affects the scalp, behind the ears, trunk, buttocks, and extensor surfaces on the arms and legs. Lesions are usually distributed symmetrically. On white skin, the plaques are pink or red, and on darker skin, plaques look grey or purple. Lesions on the scalp may be associated with hair loss. It's important to remember that psoriasis is a systemic disease. In 50% of people with psoriasis, they also have nail involvement. Signs include nail pitting, discoloration, subungual hyperkeratosis, and onycholysis, which is where the distal nail detaches from the nail bed, so the ends look yellow or white. 7% of patients with psoriasis develop psoriatic arthritis. Skin psoriasis usually develops before joint involvement, with a typical time lag of 5 to 10 years. You'll learn more about this in your rheumatology placement, but psoriatic arthritis is a symmetrical, inflammatory, seronegative polyarthropathy, often affecting the small joints of the hands and feet. So what causes chronic plaque psoriasis? It's an immune-mediated inflammatory disease. As with most conditions, it is multifactorial and results from interaction between both genes and the environment. About 30% of patients with psoriasis have a positive family history, and there are multiple genes involved. In addition to the genetic component, A number of environmental factors may trigger or exacerbate chronic plaque psoriasis. For example, streptococcal infection is strongly associated with guttate psoriasis, but may also trigger or exacerbate plaque psoriasis. Drugs such as lithium, beta blockers and NSAIDs can trigger psoriasis, along with alcohol and smoking. Sunlight usually improves psoriasis, but can sometimes worsen symptoms. Interestingly, skin trauma such as scratching, tattoos and piercings on previously normal skin can lead to the development of psoriasis 7 to 14 days later, and this is known as the Kobner phenomenon. As with many skin conditions, psoriasis is a clinical diagnosis. It is characterised by well-demarcated oval red plaques with an overlying silvery scale. It often follows a symmetrical distribution over the scalp and extensor body surfaces, but in children it may appear in the flexural areas, face and nappy region. Remember that psoriasis is a multi-system disease, so you need to examine the nails and joints too. Assess the proportion of the total body surface area affected, which can be estimated using the rule of nines, traditionally used for burns assessment. Psoriasis may present similarly to other conditions. Here are some examples to be aware of. Atopic eczema tends to be more itchy and less well defined than psoriasis. Seborrheic dermatitis may mimic scalp psoriasis, but tends to be more greasy and less well defined. Tinea, also called ringworm, is a fungal skin infection, but lesions are usually solitary and asymmetrical with central clearing. Mycosis fungoides is a type of cutaneous T-cell lymphoma, which can also cause itchy red scaly plaques, but unlike psoriasis, there is more colour variation. So now on to the management of psoriasis. As with most conditions, management can be split into conservative and medical management. In terms of conservative management, educate the patient on the condition. Explain that psoriasis is a chronic condition, so the aim is to control rather than cure it, and complete clearance of the skin lesions may not be possible. Give general lifestyle advice to reduce the risk of flares, such as smoking cessation, avoiding excessive alcohol, and weight loss. Provide information on support groups and information leaflets from websites such as the British Association of Dermatologists. Medical management of psoriasis can be subdivided into 4 categories: emollients, topical treatments, phototherapy, and systemic treatments. We will look at each of these in turn. Emollients are moisturisers and help to reduce the scale and relieve itch. They come in different forms, which all have different compositions. As with eczema, prescribe emollients according to the dryness of the skin and individual preference. Please see the eczema lecture for more details. So now on to topical treatments. First-line therapy for plaque psoriasis is a potent topical steroid and a topical vitamin D analogue called calcipotriol. The steroid works by reducing inflammation, and the vitamin D reduces the abnormal cell proliferation that occurs in psoriasis. The steroid and vitamin D need to be applied at different times of day. You can get combined once-daily preparations such as Dovabet. Review the response at 4 weeks, but advise the patient to stop the steroid before this point if the skin is clear. Vitamin D analogues are safe to use long-term. However, steroids are generally for short-term use to control flares, so you shouldn't use steroids for more than 8 weeks at a time, and you need a 4-week treatment break before restarting it again. The picture below shows psoriasis before and 6 weeks after vitamin D treatment. You can see that after treatment the patches are less scaly and thick. For scalp psoriasis, steroid and vitamin D are available as scalp preparations. If there is a poor response to topical steroid and vitamin D, there are alternative topical treatments you can try. Coal tar is a thick, black, strong-smelling liquid. It's probably the oldest treatment for psoriasis and is made by heating coal at very high temperatures. It's thought to reduce scaling and itching. It's available in various preparations, including shampoo for scalp psoriasis. However, it can be smelly and messy to apply, so it's usually not tolerated very well. Dithronol and tazarotene are alternatives and both work by slowing cell division, but their main side effect is skin irritation. so they're typically used on non-delicate skins such as the hands and knees. Salicylic acid is a keratolytic and works by softening keratin to loosen scales, so it's useful for very scaly lesions. Finally, as in eczema, topical calcineurin inhibitors such as tacrolimus are another option, but should only be used under specialist supervision. Phototherapy is another treatment option. It is useful for widespread disease or where there is resistance to topical treatment. Narrowband ultraviolet B therapy is usually used, but PUVA can also be used. PUVA involves taking a tablet called psoralen to make your skin more sensitive to light, then being exposed to ultraviolet A light. Phototherapy has a complex mechanism of action, targeting skin immune cells and keratinocytes. Most patients have 3 treatments a week for 6 to 8 weeks. Side effects include mild sunburn, dryness, itching and blisters. Systemic therapy is offered for severe or refractory psoriasis, usually after trying phototherapy. Systemic therapy can be split into non-biological and biological agents. Non-biologicals are produced synthetically and are taken in tablet form. Examples are methotrexate, cyclosporin and acitretin. Biologicals are produced through living organisms and are given subcutaneously or intravenously. They inhibit a cytokine called TNF-alpha, so reduce inflammation. Because they are very strong medications and suppress the immune system, screening tests and monitoring during treatment is required. Complications can be split into psychosocial and physical. As with eczema, psoriasis can have a significant impact on a person's well-being and quality of life. Physical complications can be split into cutaneous and involve the skin, or non-cutaneous. There are 2 severe forms of psoriasis called erythrodermic and generalised pustular psoriasis. They normally occur in people with pre-existing psoriasis and can be triggered by rapid steroid withdrawal, but very rarely they can be a first presentation of psoriasis. In addition to these skin complications, psoriasis has a number of associated conditions, including psoriatic arthritis, inflammatory bowel disease, metabolic syndrome and cardiovascular disease. The link with cardiovascular disease is complex, but one thought is that the inflammation in psoriasis can also affect blood vessels to cause atherosclerosis. So the key points to take away from this lecture are that psoriasis is a systemic immune-mediated inflammatory skin disease. There are different types of psoriasis. Psoriasis is caused by genetic and environmental factors. Management can be conservative or medical, and first-line treatment is topical steroid and vitamin D, and complications can be psychosocial and physical. Thank you so much for listening, and I hope you found this lecture useful. If you have any questions, feel free to email me on the address provided.